So we're going to talk today about vision care as we age. Vision care definitely changes as we get older. And so there's things that we want to talk about that, may affect you. It may affect some of your family members. There's certainly different people that, that age differently, but a lot of us have very many things in common. And so I just wanted to talk to you about some of the different things that we often find that people go through as they get older and some of the most common diseases that are out there. So let's go ahead and talk right now about common eye diseases that can lead to vision loss. So let me start out by talking about something that I'm sure many of you have certainly either been diagnosed with yourself, or maybe you have a family member or a friend that's been diagnosed with it. It's certainly a word that we hear a lot about, and that's age-related macular degeneration. So what is macular degeneration? A lot of folks really wonder, boy, what is that? What are you talking about when you're talking about macular degeneration? Well, let me start by telling you what the macula is. So the macula is the center portion of the retina, and it is where you're going to get your central vision from. So if you're looking straight ahead at something, and I know my camera gets a little dark here, but if I'm looking straight ahead at my computer screen right now, I'm using my maculas to go ahead and view that. And that's the center portion of the retina, like I said. What happens with macular degeneration is we start to see a destruction of that central portion of the retina, the macula. And when that happens, it can affect that straight ahead vision. And everything you use your eyes for, when you're looking straight at something, you're using that central vision, or that macula. So it can affect your reading, your driving, recognizing faces. You may come into a room and look directly at somebody, and maybe you'll recognize their shape or perhaps their voice, but you may not recognize their face. And that can happen with macular degeneration. Unfortunately, it is one of the leading causes of vision loss in Americans 60 years and older. And about 20 million adults in the US right now have some form of macular degeneration, whether it be a very mild form or a much more severe form. And what are our risk factors for macular degeneration? Well, we know that age is certainly, and you can see it right there in the title, age-related macular degeneration. That's the most common risk factor. But genetics play a role. Do you have it in your family? Smoking status, I got to tell you, smoking can be really tough on you, just your entire body, but we know that smokers have a higher incidence of macular degeneration. And then just nutrition in general, and we'll talk about that as the slideshow goes on. So what are the types of macular degeneration? Oftentimes you'll just hear people say, oh, I have macular degeneration, but what kind do they actually have? They may have the dry kind, or what we call the non-exudative, but for purposes here, for lay purposes, we'll talk about it as the dry kind. It's the most common type of macular degeneration. It affects about 90% of the cases. And it may change over eventually to what I'll talk about next, and that's the wet kind. But in the dry kind, the cells just slowly degenerate over time. It's much more gradual. It's something that generally doesn't happen overnight. It takes a longer time to develop. And it is, like I said, the most common type out there. And then we have the wet kind, or the exudative kind. Well, what does that mean? Well, the wet kind means that there's fluid or blood that are leaking from the vessels that feed into the macula. There also may be new small blood vessels that form there that we don't really want there because they're the leaky type. Now, fortunately for us, this accounts for only about 10% of the cases. But unfortunately, it also accounts for about 90% of legal blindness that occurs, because it is a much faster type of macular degeneration. It occurs much quicker, and it moves on a much faster scale. And so this is something that people may come to us almost overnight and say, hey, just last night I noticed that my vision drastically changed. And so that is something that we oftentimes will see in an acute situation in our clinic. Now, everybody that has the wet kind of macular degeneration had to have had the dry kind at some point. And so the dry kind will change over to the wet kind. But sometimes you're not diagnosed with the dry kind first because maybe it's been a couple of years since you've had an eye exam, and so maybe you never knew that you had the dry kind. But that will always precede the wet kind. So let me show you a couple of pictures. This is dry macular degeneration. Now, this is the back of the eye. This is the retina, and this happens to be the right eye on somebody. And this is over here where you see my cursor is the optic nerve. Over here in this center area is the macula. Now, what you're looking at there, those white spots there, and I know this is kind of a picture you've probably never seen before, but these white spots here, those all make up the process of macular degeneration. So when we see this in somebody's eye, we know they have macular degeneration. Now, this is the dry kind, and I'll show you how I can tell the difference. This is the wet kind. So this is all blood and fluid that's leaking into that center of the retina. That is the wet type of macular degeneration that we were talking about. So what do we do about it? Well, the dry kind, you may hear people say, well, gosh, there's no treatment. My doctor told me that I don't have any way to treat this. There's no treatment for it. Well, that is true, but you may have seen some of the ads out there, some of the television ads talking about a new treatment and saying, if you have dry kind of macular degeneration, ask your doctor about this. It's called Syfovre. Well, that is actually for much more advanced types of macular degeneration, more advanced types of the dry kind of macular degeneration. For the mild or the moderate types, we still don't have any treatment, but we definitely have some recommendations. And the first one is what's called AREDS 2. Now, some of you may know this as Preservision. So your doctor may have said, hey, go ahead and take Preservision. That's just a brand name of AREDS 2. So what is AREDS 2? Well, that is a formulation made up of vitamins and antioxidants that we know help slow down the progress of macular degeneration or help delay the onset of the wet type of macular degeneration. So AREDS 2 stands for Age-Related Eye Disease Study 2, and that is because they did it for a second time. They came up with a new formulation. That study resulted in this formulation that's available over the counter. So we recommend that a lot to our macular degeneration patients. We also recommend green leafy vegetables. Now, some of you may be on blood thinners and maybe your doctor told you not to take green or eat a lot of green vegetables. And that's true. But in a case of somebody who isn't on those medications and can do this, we do recommend those green leafy vegetables. So what are green leafies? Kale, spinach, romaine, lettuce, broccoli, all of those type of things. We also recommend sunglasses. We know UV light is very devastating to the eyes, both in the case of macular degeneration, cataracts as well. So we recommend sunglasses to everybody, even on a cloudy day. If you're out there on a cloudy day, the sun, the UV light is still getting through. And if you're a smoker, discontinuing that as soon as possible. And I know that that is easier said than done. We also generally ask our macular degeneration patients, our dry macular degeneration patients, to come back to the clinic about every 6 months to a year, depending on the severity. And the wet kind is completely different. That we definitely have treatments for. And so our first line of business when we see that somebody has wet macular degeneration is to send them over to a retina specialist. What the retina specialist will do is generally, not always, but generally use injections into the eye. Now, I know that sounds awful for any of you that might not have ever experienced an injection in the eye. You might think I could never do that. It sounds terrible. It's really not too bad from what my patients have told me. I've never had it myself, but what my patients have told me, it's not too bad. They go into the white part of the eye, the sclera. You don't have a ton of feeling in that area. They also are going to numb that area up. But what do these injections do? Well, what they do is they stop that bleeding. They dry up that fluid that's in there and hopefully at least to some degree improve the vision, but also stop it from getting worse. Those injections can be given every 6 weeks, depending on what the retina specialist wants, but they can go further out. So as we see stability in a patient like that, and we're not seeing a lot of new bleeding, the retina specialist will go ahead and hopefully spread those treatments out. Some patients only need a few treatments. Some patients may need several of those injections. And the recommendations otherwise are the same as what we talked about with the dry. The AREDS 2, the green leafy vegetables, no smoking, and the sunglasses. So that is macular degeneration. Let's talk about probably the most common thing and what many of you probably have either experienced or certainly have somebody around you that has experienced, and that's cataracts. Now, cataracts are the leading cause of vision loss in patients over the age of 60, but we have a treatment. We have a surgery for it. So even though cataracts seem like, boy, it's really a tough thing to go through and it may make your vision worse for a period of time, we always have that option to send you for surgery. So what happens with a cataract? Well, it's actually in the lens of the eye. Sometimes people will say, gosh, I have heard that cataracts are a film over the eye, but they're not actually. The lens of your eye sits behind the iris, the colored part of your eye, and the pupil, the dark part of your eye. And so in that lens, it will start to become yellow or take on kind of a cloudy appearance as you get older. Now, I kind of liken it to if you take a newspaper, a clipping of a newspaper that you stick in your closet for 20, 30 years. becomes yellow over time. The lens of the eye does the exact same thing. But again, like I said, a surgical procedure can correct that problem and restore the vision. Now, most people over the age of 65 are going to have some level of cataracts, so we expect that to happen, but not necessarily will you need surgery. So the cataracts develop usually gradually, but they're at different rates for different people. So sometimes people are having surgery at a younger age. Sometimes people are going, their whole life without ever requiring that surgery. When do we talk about surgery? When do we say, hey, it's time to go for surgery? Well, it's when it really affects what we call your activities of daily living. So you're driving, you're reading, you're watching television, if you're working still, those types of things. If it's getting in the way of the vision, we want to talk about surgery. Now, there are some restrictions on surgery. We do have to wait until they get, quote unquote, bad enough. Some of you may have heard of that years ago being called ripe. We don't use that word much anymore, but we do have to wait until they get bad enough. And part of that is because we do have, some obligation with insurance companies. They do prefer that we wait until a certain point, but it's not just the insurance companies. It's really, we don't want to go in and take an unnecessary risk. So we don't want to go in and do cataract surgery on you unless you really are going to benefit from it, unless we really see that that benefit is going to be there. Cataract surgery is very low risk. The risk is complications are less than 1%, which is very, very low, but there's always a risk anytime any surgery is done. And so we don't want to do that at a point where maybe the benefits of that are not going to be enough. Now, there are some kind of cataracts that can form in younger people, congenital cataracts. Newborns can be born with cataracts, and cataracts caused by medications such as steroids. So when we see somebody that's been on at a very young age that has cataracts, we'll say, have you ever been on a steroid or any other kind of medication at all that may be certainly causing this to be an issue? And so sometimes that will happen, but the vast majority of people who have cataracts are the folks who are over the age of 65 or so and just developing what we consider to be a normal age-related cataract. Cataract surgery is outpatient. It's relatively painless. You usually go home in a couple hours. You can stop for lunch on the way home. I mean, it's certainly a very straightforward surgery. Probably the biggest thing we hear complaints about are drops that have to be used after surgery, and those last usually around 4 weeks or so. And that's to avoid any kind of infection and the inflammation that comes with surgery. What does a cataract look like? When we look in there to see it, on the left-hand side, you'll see what we call a nuclear cataract. That's happening in the nucleus or center portion of the lens. And so that's where you start to see that yellowing. You're going to see that kind of a yellow change to the lens. And on the right-hand side here, you'll see a cortical cataract. That's happening more in the outside, so the cortex of a lens, which is more of the periphery of the lens. We see that more of a spoking. You can maybe see on my pictures here, it looks more spoke-like. Sometimes, and very often, it will start as a nuclear cataract. We'll see some cortical cataract developing, and you'll have what's called a combined cataract. So these two will look very, like they're combined into one picture. So that's what a cataract is. Let's talk about glaucoma. Glaucoma is probably one of the least understood diseases out there. And it's a very interesting disease, actually, and something that affects a lot of folks. What is glaucoma? Well, glaucoma is when the pressure in your eye raises to a level that's harmful to your eye. Now, the reason I say the pressure in your eye is because what your eye can handle may be different than what my eye can handle or what your family member's eye can handle. And so it's a little bit of a judgment call. We look at the number, at the pressure, but we also want to know how the optic nerve looks in the back of the eye. When the pressure goes too high for your eye to handle, and there's a couple of reasons why this can happen that I can talk about briefly, damage can occur to the optic nerve in the back of the eye. When damage occurs to the optic nerve, we'll see a slow, progressive loss of your peripheral or your outside vision. So it doesn't affect your central vision like macular degeneration. It affects your outside vision. If glaucoma were to go unchecked for many, many years, it can cause a tunnel-like vision. But fortunately, if you're going for a regular eye exam, glaucoma should be picked up before it ever really causes you any real damage to your eye. Now, in some cases, very few cases, it can progress no matter what we do. But in most cases, as long as you're having a regular dilated eye exam and other tests done, we'll go ahead and pick that up. the reason you have pressure in your eye in the first place is that your eye is kind of like a fountain. The inside of the eye continues to make fluid. It bathes the inside of the eye. These aren't your tears on the outside, but fluid on the inside of the eye. It also continues to be drained off, and then your eye makes more. So it continues to be kind of a nice process like that. But in some people, either their eye is producing too much fluid or their eye is not draining the fluid fast enough. That's what causes the pressure to rise inside of the eye. And again, that's what causes the damage to the optic nerve. Now, historically, treatment for glaucoma has always been with eye drops. That's usually what we're going to use first. But surgical intervention is normally something we went to way down the road. But there's some newer procedures called minimally invasive glaucoma surgeries. They're called MIGS procedures for short. Those are more frontline surgeries. We're going to those a little bit sooner than what we were doing before because they can be done at the same time as cataract surgery, or they can be done a standalone type of procedure. And they're, again, called minimally invasive for a reason. They're very, very simple as far as surgeries go. It's very straightforward. So those are some procedures that we are also going to a little bit sooner now. What does glaucoma look like when we see it in the eye? This is, again, your optic nerve. The center of your optic nerve is called your cup. In glaucoma, this one on the left-hand side is normal. In glaucoma, we're seeing this cup enlarge quite large. And that's simply because if you think of this like a cake donut, the hole in the middle of the cake donut is getting larger because the rim, the outside of the donut, is being eaten away from the inside. And so that's what we see in glaucoma, and that's what we're trying to avoid, because this picture on the right-hand side probably is causing some damage to the peripheral vision already. Diabetic retinopathy is another thing that definitely can affect the eyes and cause vision loss. Over time, diabetes can damage blood vessels. Well, it can damage blood vessels in your entire body, but it can damage blood vessels in the retina. And that will occur and diabetic retinopathy occurs when those blood vessels leak their blood and other fluids into the back of the eye. The retinal tissue back there can also swell. This can affect both eyes at the same time. In fact, usually it does. It can cause you to see spots, blurred vision, dark spots, or empty spots in your vision. But a lot of people have no symptoms at all early on. In fact, sometimes we are diagnosing diabetes because we are seeing people for an eye exam. We look at their eyes, we see the bleeding happening, send them over to their primary care doctor, and they can be diagnosed with the diabetes that way. So this is just a drawing, obviously, but on the left-hand side, you'll see normal. On the right-hand side, you'll see that you have kind of these, what we call cotton wool spots, which is just the inflammation, and then some different blood vessels here. This is what diabetic retinopathy looks like. And here's a real picture of it. You can see some blood leaking in here, and then some swelling of the tissues as well. And then we can also see bleeding in the retina like that with diabetic retinopathy. We can see bleeding into the vitreous, which is the gel substance in the back of your eye. And we can see swelling in the middle of that area, and again, that macula. I won't go into this, but this is just one of the ways that we look at your eyes. We use these scans that give us a good idea what the back of the eye looks like. All on this side here, this is all swelling in the back of the eye that can be occurring due to diabetic retinopathy. So how do we get rid of that? How do we take care of diabetic retinopathy? Well, again, retina specialists take care of this. We can do injections into the eyes. There's lasers that can be done, but the most important thing is controlling the blood sugar. So if you are diabetic and you keep your blood sugar under control, you likely are not going to end up with any diabetic retinopathy. It's when that blood sugar gets out of control or stays out of control for a number of years that we start to see the diabetic retinopathy occurring. I'm just going to talk briefly about what is legal blindness. We hear people say, I'm legally blind without my glasses. Well, in reality, that's not the definition of legal blindness. Legal blindness means you have the best corrected vision on. So you have the best vision we can get you as far as with glasses, the best prescription we can give you, and you're still only seeing 2200 or worse in your better seeing eye. Now, why do I talk about this? Well, some of the folks that have some of the diseases that we talked about, diabetic retinopathy, macular degeneration, or glaucoma, may qualify to be considered legally blind. And we can write a letter that will say that because you may qualify for different kinds of SSI or Social Security type of things, and tax deductions as well that do exist. There also are state agencies. So if we have somebody at a younger age that's still trying to work, there's state agencies that will help people with work training who qualify as legally blind. And again, we talk about just some things with folks who are struggling with their vision and some different low vision aids, such as magnifiers and telescopes, check writing guides. And these are all things that you can certainly talk with your eye doctor about. There's also a lot of things available online now such as these magnifiers and telescopes. Magnifying devices that help if you go to the grocery store or such. Closed circuit televisions, these go in your home. Obviously, you can't throw that in your purse and take it to the grocery store, but it certainly is something that's nice where you can place pictures or reading materials underneath and it'll bring it up on this big screen here. These are really kind of nice, but they are around $2,000 or so. So for some folks, they find that to be a little bit of out of their price range and a little bit cumbersome, but they really are a nice option. We have talking glucose meters for people who are diabetic that might want to use these so that it reads out what your blood sugar is, as opposed to you having to try to read the screen. And I'm sure we have all seen these white mobility canes out there. If you see somebody walking with a white cane with a red tip on it like this, or even down on the very bottom a red tip, you can rest assured that they probably do struggle with their vision, probably a low vision patient, and certainly may need some assistance. Thank you so much. I appreciate all of your attendance, and certainly we're going to, I think, open it up for questions now. And yes. I know that some of you did submit questions, and we can talk about those too, but we are going to be sending out, I'm going to go ahead and go through and do a comprehensive answer of those questions as well, so that we'll be sending out.
Perfect. Thank you, Dr. Dillon. I have not seen any questions come through our chat. So if folks are comfortable, they can certainly go into that chat feature and type a question. But we received quite a number of questions submitted in advance of today's webinar. So we will get through as many as we can today. And then as Dr. Dillon mentioned, we'll send out a follow-up communication and make sure everyone's questions are answered. So the first question, Dr. Dillon, was related to cataract surgery. The question was, could you provide any information on the newest cataract procedure that also improves vision? And is there any Marshfield Clinic Health System physicians that are performing this procedure?
So I think what this question probably is referring to, a lot of times after cataract surgery, folks don't need to use their glasses anymore, or they may only need to use their reading glasses. So in a normal cataract surgery where they are just putting in what we call a standard lens implant. So I should talk about that. When you remove, and because I don't know that I touched on that, when they remove the cataract from the eye, they're removing the entire lens. And so in its place, they need to put a lens implant. Now we can choose any power we want for that lens implant. And so oftentimes what will happen is when they put the lens implant into the eye, they can choose a power that will hopefully negate whatever your distance prescription was before you had cataract surgery. So we can get that hopefully as close to being zero as possible for your far away vision. Now, that is not always necessarily a perfect system. Sometimes the measurements don't allow us to be precise with cataract surgery. But in recent years, they have come out with what we call premium lens implants. And those are lens implants that either can take care of large amounts of astigmatism that maybe weren't available in a lens implant as a standard lens implant, or we can do a multifocal type of lens implant. And again, that's something that's going to help with both the distance and the up close, because in a standard lens implant, it doesn't help your reading. So you're still going to need reading glasses. But in a multifocal lens implant, it can help with your up close. Or again, a toric lens implant, which can help with the astigmatism. And that is something that the surgeon will certainly make the judgment call on and can talk to you about at the time of your surgical consult. They are more expensive. Insurances do pay for the standard premium lens, or excuse me, the standard lens implant, but the premium lens implant is more expensive. And I believe the cost at Marshfield right now is $1,800 per eye. That changes a little bit just based on the particular type of lens implant, but it's right around $1,800 per eye. And yes, we do have 2 surgeons who are doing those.
Great. Thank you, Dr. Dillon. We did receive just a question now in our chat feature. The question is, sometimes when I go outside during the day, I see sparkles. Is that something we should be concerned about?
Well, it depends. That is definitely something I would encourage you to talk to your eye doctor about. If it's something that's been going on for a period of time, it's probably not emergent. But if it's something brand new, you certainly may want to call your eye doctor's office and speak about it, or talk to your eye doctor when you do go in. Sparkles can occur just depending on, well, there's a lot of reasons why sparkles can occur. They can occur because of the fact that you could get kind of a reflection, which oftentimes can happen, when you're going outside, especially on a bright sunny day, or a bright day with the snow that we have right now. You can get kind of the reflections that come off of the snow. So sparkles can occur for that reason. Sometimes the sparkles are happening in both eyes, and it may not even be coming from your eyes. It's possible that could be happening due to something in your health, maybe when you're changing positions or something along those lines. So I would encourage you. There's a lot of questions that we ask the patient when we hear something like that. So I would definitely encourage you to talk to your eye doctor about that and kind of go through the different options that could be causing that.
Great. Thank you, Dr. Dillon. We also received a couple of questions related to dry eye. So I think folks may be just looking for any new treatments or anything in specific they can do to get some relief for dry eyes.
Sure, dry eyes are a tough one because, boy, we all experience them. I feel like here in Wisconsin, especially, and in the winter, in the wintertime, you're indoors a lot. And so you're going to be in the heat, you're going to be in an area where it's probably drier. Or if you're going to a large store or a mall or something like that, you certainly are going to experience a drier situation. So what do we do with dry eyes? Well, the first thing, and as you probably many of you know, is lubricating drops or over-the-counter moisturizing type drops. Now, I will say this, and this is something I tell everybody: you avoid whatever says it's going to get the red out. So you don't want Visine or Clear Eyes or any of those. You want just those good moisturizing drops or lubricating drops. Some of the names that we recommend, some of the brands are Refresh or Sustain or Blink or Soothe, and I can write all of this into the comments that we're going to send out later, so you don't necessarily have to scramble to write this down. But those are all drops that we recommend. So a lubricating or moisturizing type of drop. I usually recommend people use those on a regular basis, even if you're feeling like, boy, this is a day where I really don't have a lot of irritation or pain. I still recommend putting maybe a drop in the morning, maybe a drop before you go to bed at night. And then you can use more throughout the day if you're having a particularly bad day. So drops definitely help, but we know that it's not necessarily easy for people to just be putting drops in all day. Maybe they're gone, maybe not at home, and you can't necessarily throw those drops in all the time. So other options that we certainly talk to people about: one, staying hydrated yourself. So drinking water, I think in general, we just don't drink enough water, as a society. I always take my big old mug here to work every day, fill it up with ice and water in the morning, and try to drink that throughout the day. So staying hydrated really can help your dry eyes as well. The other thing that can help is humidifiers in your home. So if you have a whole house humidifier, great. If you don't, a humidifier in your bedroom can be very, very helpful. If you're somebody that uses a CPAP machine, make sure you have a very, very good fitting mask that you're using. That can definitely cause some dryness. The leakage of the air around those, or even just the CPAP in general, can cause some dryness. If you are somebody that uses that and you have a good fitting mask and you're still having issues, there's gel drops that can be used at night. There's also gels and ointments that can be used at night. Those companies that I mentioned, or those brands that I mentioned, Refresh and Sustain, they have ointments and gels that you can put in at nighttime. Now, be warned, it will blur your vision. So if you are going to get up and go to the bathroom during the night, or if you're, looking and trying to use something that wakes up and you're trying to read or something, that ointment or the gel is going to blur your vision a little bit. So you just want to be aware of that. You don't need much, just a little bit, a 1/4-inch strip is all we tell people. Pull down your lower lid, put a little bit in there. It's going to help kind of keep you moisturized through the night. Even if you're not somebody that uses a CPAP, you may want to consider that, because then you'll wake up kind of ahead of the game. You don't have to worry about kind of playing catch up in the morning if your eyes are dry. They also make heated moisturizing masks. You can get these from Amazon. You can get them at Walgreens, Walmart, CVS, any of those types of places. You put it, it looks just like a sleep mask, like a mask you would put over your eyes, but they have gel beads in them. You throw them into your microwave for about 30, 40 seconds, depending on what the instructions on your particular mask is, and it stays warm for about 10 minutes. So you lay it over top of your eyes, kind of feels like a spa. It's lovely. But that helps actually stimulate the glands in your eyes to produce more of those tears. And so we do recommend that. I usually tell people use that once or twice a day as well to see if that makes a difference for you. You've tried all of these things and you've done everything and you're still at a situation where you're thinking, boy, my eyes are still dry. Your eye doctor may recommend a prescription eye drop. There's three over on the market right now, three prescription eye drops. They all work a little bit differently from each other. The only thing about them is that they can be quite costly and they can take a while for them to really start working. But it is something that you can discuss with your eye doctor if you think potentially you may be a good candidate for one of those prescription eye drops.
Great. Thank you, Dr. Dillon. We've
You're
got so
welcome.
many questions to get through. I'm going to go through one more because we are at the top of the hour here. And then the rest, I promise that we will answer everyone's questions and get answers from Dr. Dillon and share those with everyone. But the final question today we'll address during the live webinar. Does inverting or hanging upside down, maybe due to a spinal stenosis or any other kind of condition, does that have an adverse effect on one's eye pressure?
No, it does not. Your eye pressure, again, is only going to fluctuate based on what we talked about before with that fluid going through the eye. And you do not have to worry about that. That drain for the fluid is 360 degrees in your eye. So you don't have to be upright. You don't have to be in any certain position for that drain to happen. It's going to be draining 360 degrees around the eye. So invert away. Go ahead. If it works for you, you can definitely do it.
Great. Wonderful. Well, Dr. Dillon, thank you so much for all of the great information today. And thank you to all of our wonderful participants for joining today. Watch your email inbox. We'll be sure to get everyone's questions answered and share that recording with you too from today's webinar. So everyone's try and stay warm out there and we'll see you next time.
Thank you. Thank you all for coming. I appreciate it.